Good afternoon. Welcome and thanks for joining us for today's HISTalk webinar. Your call is very important. It's brought to you by West Healthcare Practice. I'm Lori from HISTalk and I'll be moderating. We have two presenters today. First up is Brian Cooper, who's a Senior Account Executive at West Healthcare Practice. Joining Brian will be Cyndy Orrys. Cyndy is the Contact Center Director at Henry Ford Health System. With that, I'll turn it over to you, Brian.
All right. Thank you, Lori. Appreciate it. Thanks, everybody, for taking time today to spend an hour with us. Again, my name is Brian Cooper, and I am part of the healthcare practice here at West Corporation. I've actually been in the industry for about 20 years. All that time in technology, a good portion of that time has been in operations. So I've been a part of the healthcare practice here at West for about 3 years. So I've spent a lot of time in the market, really talking to a lot of you and some of your peers out there, small, medium, and large health systems, particularly about patient access and how technology can really help drive a better patient overall experience, as well as drive better outcomes, reduce cost, and increase revenue. With me today is Cyndy Orrys, and she will be speaking after I'm done kind of providing you some overview. So what we're going to talk about today is really three things. First of all, when you think about leveraging technology in an access center or a contact center environment from a healthcare perspective, it's important to think about it from a crawl, walk, run standpoint. If you're thinking about modernizing your contact center or creating a consolidated access center environment, that's a huge task to undertake. So doing it in a phased approach is critical to success. The second piece is really what key characteristics should you be considering as you're looking at going down this path. So we'll go over 5 of those key characteristics and share some of our insights in that area. And then we'll end with Cyndy really going through her case study and talking about how Henry Ford has worked to create kind of a world-class patient experience from a contact center modernization perspective. So as we go into this conversation, when you look at your contact center or even your access center environment, you may not have a single contact center. It's good to assess where you sit in kind of the maturity curve from a transformational perspective. So again, this is really the crawl, walk, run approach. And when you look at these different stages, we kind of define the crawl stage as creating an environment that starts with a single front door. So one of the key challenges that we typically see out there in the market is health systems that have hundreds, potentially thousands of phone numbers on their website that have been posted over the years. Patients have got them in their speed dial, and they're just comfortable calling a certain number. So what that creates is, when a patient goes to try to schedule an appointment, whether they're an existing patient or a new patient, they sometimes struggle to find which number should they dial in order to get into your health system. So the idea of creating this single front door access point with think of a vision of a 1-800 health system phone number that's an all-encompassing number that can be marketed to patients and providers as a single access point where they can get any question or issue resolved. So creating that unified, consistent patient experience is critical, and that's really the key starting point. As you get into the walk phase, which is the next step, you're starting to look at what we kind of look at on the commercial side with large enterprises that are continually fighting for subscriber bases and customers, is creating a truly connected patient experience. And that's being able to really see that patient across communication channels, getting more intelligent in terms of how you deal with that patient, and then using that information to even potentially be more proactive in engaging that patient. And that's our last area, which is really when you're up and running, you've got the foundational components of the crawl and walk elements, and now you're looking at, how do I max this environment? And it's really looking at how can I be more predictive in my approach and more prescriptive as I engage patients. So really quickly, I'll go through each of those, couple examples of where you can find value in technology. In talking to a lot of health systems, a lot of them are fairly segmented. They don't have consolidated contact center environments. They've got 19, 20 plus different skill groups or pods or specialties, depending on how you look at those groups. And they're struggling with, how do I bring all those calls into a single environment instead of having calls land in one place, potentially transferred to another place, then transferred to another place where they sit on hold for 10 minutes, and now you've created a bad experience for that patient. So when you look at that crawl stage, really you're looking at it's not simple, but it's a straightforward approach of redirecting those phone numbers that you've got out there on your website or that patients might get a hold of, and redirecting those into a single application. And then that application can do some pretty good triage on that call to identify, really it's about why are they calling first. So you want to identify why a patient or provider is calling, because there are, as you know, a lot of calls, sometimes 50% or more, that come into an access center environment that aren't scheduling related. And those are great opportunities to be able to peel those calls off at the front door and redirect them accordingly without having to put the patient through an authentication process. So if you can identify why they're calling, well, I'm looking for directions, or I need some information, or I need to talk to somebody in the hospital, those are calls that can easily be transferred off to the appropriate place. The second piece is use bidirectional intelligence. So take what you know about the proactive outreach that you're doing today, and specifically low-hanging fruit would be appointment reminders. So if you sent an appointment reminder to a phone number, 402-555-1212, and now that phone number is calling back in to this single front door, you don't necessarily need to know who that person is. You recognize the phone number, identify that you've placed an outreach to that number, and now you can dig into that outreach file and say, oh, that was a reminder to Brian Cooper about his appointment with Dr. Smith at 2 o'clock tomorrow. So now you have some information that you can leverage to either redirect that call immediately to Dr. Smith's office, or even do some additional triage on that caller, or perhaps even authenticate that caller. Speech recognition technology helps out here a lot. So I've encountered a lot of menus where you get into a certain clinic or medical practice where you've got multiple physicians, or you get into an environment where you've got multiple specialties that a patient is looking for, and there are actually menus that are 10, 18 options deep, where the patient has to listen to every single option before they get to the one they're looking for. So speech gives you the ability to ask the caller what they're calling about. So they can say, oh, I'm calling about neurology, or my doctor told me to schedule with Dr. Smith. And we can use that information with speech technology to quickly route that call immediately to where it needs to go. The last piece is the intelligent routing component to identify, where does this call need to be routed? Should it go to Susie at Dr. Smith's office, or should it go to a centralized scheduling center that does the scheduling for Dr. Smith? So when you get into the walk stage, now you're using more information. So you've got that foundational set of information from the crawl stage, and you've got some patient interaction data to leverage. Now you can tap into back-end systems like EMR systems. A lot of health systems now are looking at CRM data and billing systems to even do more within self-service. So if you know why somebody's calling, it's about an appointment, now you can ask for a couple pieces of information, date of birth, last four of social, and now you can authenticate that patient and say, oh, I see you're calling about your appointment. Would you like to confirm or cancel? And if it's a confirmation, you can give them confirmation details, and perhaps that's all they need. So they don't even need to be transferred to an agent, which helps save those calls that go to agents. It peels off kind of the less complex calls and leaves the more complex calls for the agents to handle, creating efficiencies inside your contact center or scheduling environments. The other piece that we're seeing a lot of is using the voice channel for these phone calls to identify callers on mobile phones, and then using that information to opt in those callers into the SMS channel. So SMS, I'm sure you're all aware, is a very fast-growing channel, very widely adopted among all demographics, really. And so it's a great way to open up another line of communication, another channel of communication, and then load that opt-in into your preference management database as well. So then finally you get to the run stage. So this is where you're really starting to get a 360-degree view of your patient. You're starting to see them across channels. So the idea here is that you've got a patient who maybe has gone to the portal to refill a prescription or to pay a bill or to try to schedule an appointment, and then they, for whatever reason, can't resolve what they're looking to accomplish, so they pick up the phone, they call 1-800-HEALTH-SYSTEM, and that health system immediately knows that they've been on the portal trying to refill a prescription and says, oh, I see you've been on the portal, or maybe not. Maybe it doesn't go that big, brother, but maybe it just says, oh, are you calling about your prescription? And redirect them straight to that area. So you get rid of those static menus that everybody is so tired of with automation, and you collapse the menu. You create a much more personalized experience that's highly intelligent, and you get them exactly where they want to go right out of the gate. The other piece here is to see a patient across the care continuum. So for example, in a transitional care scenario where the patient's just been discharged, you could leverage that information if a patient's calling back to schedule a follow-up with a physician, and perhaps you need to get a survey taken with that patient, or you need to connect them with their care coordinator. You could actually acknowledge that on the phone, let them handle their scheduling piece, and then redirect them over to their care coordinator. So this front door can also help drive better overall outcomes in transitional care, routine care, and chronic care environments. So really quickly, in terms of the characteristics that you need to be thinking about as you're moving either into crawl or from crawl to walk or walk to run, they fall into 5 kind of core buckets. One is the cultural environment that you're in, and we'll go into each one of these in a little bit more detail. The other is data availability and consistency. How much data is available? How consistent is it and reliable? Are you looking to centralize your contact center or scheduling operations? Do you have existing, consistent, consolidated scheduling templates? And then, how can you leverage those 4 things to institute a front door environment? So the first area is really the most important. I was at a conference recently for contact centers in healthcare, and one of the speakers mentioned that if they had to rate, the most important element to get over as you're looking to modernize a contact center, it would be culture by 3 to 4 times any other consideration. And I would totally agree with that given my experience. So when you think about your culture, think about how prepared is your culture for change. Is your organization ready to make this change? What are the potential roadblocks to your success? Do you have executive support for what you're trying to accomplish? And are there key strategic initiatives and imperatives at the CEO or C-level to help support what you're trying to accomplish? The other thing to consider when you think about the cultural readiness for modernization is the idea of leakage to keepage. So we talk to a lot of clients and prospects about revenue leakage, which is something that CMS makes available, and it really shows the revenue that could be coming into your health system that may not be because of challenges getting into the front door, or it could be patients that you already have that end up moving away from your health system because of challenges getting access to your health system. So if you're thinking about, ways to make the business case and get cultural buy-in, certainly cost savings and patient experience are great metrics, but looking at revenue and revenue opportunity is also key to creating a culture that's ready for change. The other thing, just logistically on these slides, and I know you'll have access to these after this event, is we tried to put some key questions in each of these slides so that you have some things that you can use as follow-up, so that you're prepared to take that next step. The other issue and challenge and consideration that I run into quite a bit is the availability of data. So how available is the data? And the data could be clinical data through an EMR, could be behavioral data through a CRM type system, or it could be visibility into operational data. So one of the challenges that we run into a lot in the access center environment is that health systems can't see what's going on. They don't have any visibility into the number of calls that are coming into the health system. If they do have visibility into calls, they don't know exactly why patients are calling. So not having access to that data can be a challenge. Certainly having access to EMR data is important. So when you think about things that position you for success, you want to look at making sure that you're on a single EMR platform. There's a lot of health systems that are in the process of migrating from 2 different EMR systems into one, or perhaps upgrading from an older version of an EMR platform to a newer version. So those are things that you want to make sure that you're thinking about. Also, a key component is analytics. So in order to make good decisions and drive relevant, meaningful, and actionable insights, you need to be able to have access to data. So having consistent and data that you can trust is important to be able to drive that analytics component. The third consideration is really around centralizing your operations. So you can still gain significant value from a single front door environment without having centralized operations. So in the call scenario, I mentioned that you can have that single front door that can triage the calls, and it can effectively route those calls to separate groups of people or even individuals without having centralized operations. But if you're at a point where you're looking at centralizing your operations, it's a great way to drive efficiencies inside of your contact center. So as you do that, one of the key components is looking at a centralized phone system. In a lot of cases, we've got we're working with health systems that have old technologies, old PBX technologies, old end-of-life technologies that don't provide the opportunity for data visibility or intelligent routing. So being able to get all of your agents, whether they're in a single environment or not, on a single centralized phone system is critical, and that'll give you the visibility that you need inside of your contact center. The other is to provide your agents the ability to schedule multiple physicians or specialties. So multi-skilling agents or having universal agents gives you significant opportunity around gaining efficiencies within your contact center environment. And then the last piece is really business continuity. We've ran into several health systems that are single-threaded from a contact center perspective, and due to snowstorms, inclement weather, or God forbid some sort of disaster, that center becomes unavailable. Now they have no way to take calls because the agents aren't on a single centralized phone system, so they can't log in from home, they can't work remotely, and they don't have a second site available. So think about your business continuity plan and how you can handle scenarios where either service is degraded or that facility becomes completely unavailable. The fourth area is really implementing and or consolidating your scheduling template. So this is around getting consistent with your scheduling. So if you are in a position where you're perhaps rewriting your website You're allowing patients to schedule self-serve via the web or via the portal. The front-end IVR system, or the front door, can access those same templates and can do true end-to-end scheduling, which is something that we've been doing in the voice self-service environment for many, many years for cable companies, utilities, and those types of things. So it's very doable with an IVR. It's just getting access to that data. So when those templates become available, that's a great time to start thinking about using those templates in the voice channel to offer complete end-to-end scheduling in a self-service environment. The other piece is really with mobile applications. I know in talking to a lot of health systems, there's this idea of kind of open table type scheduling, where you allow the patient to schedule via open table types of applications, where they get 3 or 4 options for a physician. They can choose the one that best suits them. We can use those templates as well. So with those 4 considerations, really, the question is, how do you go about, or how can you leverage those to institute your front door? And the idea is, again, being proactive, consistent, creating a unified branded experience for your patients, and one that's intelligent and personalized each and every time that patient calls your health system. So think about, is your culture ready for change? Do you have data consistency and reliability? Do you have centralized scheduling? If not, that's okay, but just understand how to navigate that environment. And then how can you use templates to do more self-service related to scheduling? So hopefully this has been helpful. I'm going to hand it off now to Cyndy and have her walk you through specifically the Henry Ford example. Cyndy?
Thank you, Brian. Good afternoon, everybody. Like Brian said, I am Cyndy Orrys. I'm the director of the contact center here at Henry Ford Health System. I have been in the contact center for 10 years. We've been on this journey that we're on today for about 9, so I have been part of the process since the beginning. So I'm going to talk about how we got to where we are today. So just to set the stage a little bit and give you a little bit of an overview, we just celebrated our 100th anniversary of our hospital. We have a very large footprint in Metro Detroit as an employer, and then also as a health system. We have 6 hospitals. We recently just acquired a hospital in the west side of the state in Jackson, Michigan. So we're trying to expand our footprint more throughout Michigan. A very large medical group that the contact center supports with over 1,200 physicians and over 40 specialties. Inching towards the 4 million mark for the outpatient visits last year. And then a good revenue year last year with $5 billion in revenue, and then our net income was $72 million. So pretty large system that we have here. So just to kind of tell you where we were, we had this vision of a centralized contact center. What we were experiencing was a very disparate experience depending on where the patient called. Sometimes you would call and get a front desk who the phone would ring off the hook. We had pocketed call centers throughout the health system that you got very different experiences, and their focus was really about answering the phone, get them on, get them off. Abandonment rates upward of 20%, multiple complaints about the wait time, and some complaints even reaching as high as the CEO's office. No real good metrics to really understand what was going on because of all the different phone systems and different standards. Some people counted every call that hung up as abandoned. Some people didn't count it till it was on the phone 10 seconds. Some were 30 seconds. So just a very different experience. So we came up with this vision to really centralize and standardize the patient experience and provide some multi-channel support with appointment scheduling through our web portal at the time, and then our calls, support the prescription refills, just contacting your provider, helping with getting a physician, doing a full registration at appointment scheduling, anything the patient really needs up through triage, which we did not have before. So we actually embedded nurses in the contact center. So I like to refer to what we've created here as kind of our virtual front desk. Anything that you would call your doctor for, the call now comes to us, and we are that first point of contact and kind of setting the stage for how Henry Ford sounds now. So here's our structure. We have 4 managers. Our calls are split almost evenly between specialty and primary care. Another role, 2 roles you may not be that familiar with, we have a manager over central support. Central support consists of our training, our workforce, our decision support analysts, quality, any of our technologies. We've actually, over time, taken ownership of many of the different initiatives that we have. We also most recently brought in this network financial clearance department, which some of you may know as insurance verification or pre-service registration. And that really gave us an ability to combine all of the front-end revenue cycle activities under this one umbrella. We also have 16 supervisors that either supervise one of our specialty pods or our primary care pods. That's what we call all of our groups pods. That's how we're set up. And then we also have this level 2, which is kind of a window to the world role. They answer for the 800 group, like 1-800-HENRY FORD. They handle any of our MyChart inquiries. They do interpreter service scheduling for the entire system. And then they are system resource. That's what ASG is. They just do some administrative resource. So having a centralized model has really been able to give the system somewhere to let things land. We went up on Epic about 4 years ago, and some of these things didn't have anywhere to land. And being centralized gave us the ability to kind of take on some of these things. As you can see, we have a pretty robust support with 8 quality coaches and 2 trainers, then our workforce team of 3, and our decision support analysts. The one thing that I will say about that is, as you think about building this, depending on where you are in your journey, make sure that you invest in the people to support the technologies that you put in. See a lot of contact centers invest in the technology of recording calls and having these tools, but if you don't have the people and you don't have the ability to actually give the feedback, the tools won't be as good. We really use things to their highest level and make sure that we implement all aspects of our workforce and quality tools to help us reach those goals that we're trying to reach. As you can see, we have 261 seats here in our contact center, but we also at this point have 69 people that work at home and more to come working at home. And the reason we started the work at home model, that was about 3 years ago, but we became landlocked. It's interesting that the better that you do, the more work people want you to take on. So we got to a point where we just couldn't take on any more services or any more things for the system because we didn't have the space. So this really allowed us to do some restructuring. It's been great for the agents that work at home. We actually have all but 2 of our nurses that work at home at this point, and it's given us the ability to continue to support the system in whatever they need. So next you'll see our org chart. So altogether, almost 400 FTEs. And I wanted just to call out a few things on the way we're set up, because this has set us up really nicely with some of the technology that we've partnered with West with. Like I said, we're set up in pods, but if you'll notice kind of in the center there, pod 1 is women's health. And because women's health has enough call volume, they answer for that entire product line. And that makes perfect sense. Now, you'll see some other pods have multiple specialties in them. If you look at pod 9, they have dermatology, endocrinology, and infectious disease. And they're set up that way because dermatology is very high volume, but it's low complexity to schedule, where the other 2 specialties have very low volume, but they're pretty complex. So that was kind of our methodology. Or like in pod 6, they have some synergy with services. You have orthopedics, podiatry, and rheumatology all in one pod. So there's been, kind of a method to our madness to try to have either things scheduled together based on what they do or based on kind of volume and complexity. The other thing that we've done is with our primary care sites, we've regionalized them. And this has also given us the leverage to offer other sites and services. So if a patient calls and they want a doctor in a certain site, that site isn't available today, but a sister site down the road 5 miles may have something open. And being that we're regional, we're able to offer those other sites and services. So same way with product line. If you answer for women's health, you answer for the entire product line. So even though this location is close to my home, I want to see the location that a doctor close to my work. So not having to hang up and call another phone number, they can answer for the entire product line and give you what appointment is best suited for your needs. It also has been really good for buy-in for the physicians. It gives the advocates the depth of knowledge in those services that they answer for, as opposed to trying to answer for so many services and potentially creating more scheduling errors. So next I want to talk about some of the challenges that we had that we were really trying to resolve as we moved further and matured further in our contact center. You know, the IT team will tell you, I've been saying for 10 years, we don't sound world class. That was a challenge. Our IT department did a wonderful job with the tools that they had, but the technology just was not going to get us to how I wanted to sound. And I realized that our customers, even though we're healthcare, they're not comparing us to healthcare. They're comparing us to when they just hung up and called their cable provider and were able to do some self-service things, or called their Visa and could find out things about their account. So they're looking at us to create that kind of experience too. And we were just too limited in the phone service, the phone technology that we had. And in order to get us where we needed to be, I couldn't just keep adding people and adding bodies. We had to start finding some solutions to how we could manage all of this call volume in a better way for the patient and a better way for the business. So we've done very well with maintaining our service levels and abandonment rates, but I wanted to focus on, you know, managing the average talk time. And when I say that, my biggest concern is I want the talk time that our patients are spending with us to be value add to them. Not having to spend so much time verifying a lot of things and really getting to what they need. The other thing that was a big issue was lack of standardization. Depending on where you called, I know Brian mentioned the old PBXs, that's the systems that we were on. And, you know, we would have some places you would call and you would have phone trees that were, you know, 4 wide and 4 deep and multiple specialties. And patients would get so frustrated and just hang up or time out and go to the wrong place. Getting to the next bullet point, they wouldn't wait to hear their option. They would just hit 0, which the timeout target would be our primary care pod, who would just then transfer them to one of the pods that answer for specialty. So it really created a bad experience. And then kind of lastly, some things we wanted to do is just create better relationships and help with appointment access. So those are the main things we focused on and talked about when we went to West for a solution. And you'll see over to the right, we take a lot of calls. When we started here, we took 2.2 million calls our first full year. Last year, we took 3.9 million. So we've almost doubled in size. So, you know, with that kind of call volume, you have to start looking at different solutions and what you're going to do differently. So like I said, we met with West, and this is kind of some of the things that, you know, we were looking to resolve some of the challenges. We wanted a IVR, interactive voice response system, that was really conversational, got people what they wanted, really added value to when they called, and when they spoke to someone, the person knew what they wanted. Prior to this, when you called, everything came in one big bucket. So the advocates, when they got the call, they didn't know who you were or what you were calling about. And that was a frustration to both the caller and the team here. So we really wanted to resolve that issue. So what we came up with was an IVR where people can speak what they want regardless of where they're calling, and then they can actually do something within the IVR. And that helps with that creating access and empowering the patient. So the best advice we got was in creating the CTI event with Epic. So we actually do a data dip with Epic. When the patient calls, the phone system does a look and sees what phone numbers match the phone number dialed with what medical record numbers. It then asks the caller to put in a birthday. And I think that was really the thing that sold me. Everyone knows their birthday. I was afraid that we were going to have to ask them for their medical record number, which most of our patients don't know. And I thought, oh, this will never work. No one knows their medical record number. But everyone knows their birthday. So if I call from my cell phone number, the system knows this could be one of 4 people, me or my family. It asks me to put in my birthday. It makes that match. And then it sends the information to the advocate of who I am because it knows who I am. Also, if I don't want to speak to an advocate, I can just look up my appointments. One of the things that we found was a really big frustration, no matter how many reminders we sent or letters or text messages, we got a lot of calls with people just wanting to know what time their appointment was. And that was just no value add for the advocate, for the patient. And this really empowers them to go, oh, yeah, it's at 10 o'clock today. I can just call and look that up. Or if they can't make it, they can cancel their appointment right in the IVR. And that immediately frees up that appointment for one of our schedulers to use for another patient. So ultimately reducing no-shows. And our first full month of being on the IVR, we had 2,000 patients actually cancel in the system. So that was a really, really big win. Now, if we can't make a match on the phone number and birth date for whatever reason, we will go down to the medical record number or the SOCH as a last resort. But for the most part, we don't have to get to those different identifiers because we're able to authenticate in about 90% of the callers. So I just wanted to give you a little view of what our team sees. Prior to this, they had nothing. So now it's really great that they can see, if you look at kind of the 4th line down, it says the patient wants to schedule an appointment. So, you know, that's great. We're not asking them all of those things. And then in the blue box, you can see it says what their medical record number is, and it says who they are. So we can now give a much more personalized experience. You know, they could say, good morning, Miss Orrys, or good morning, am I speaking to Miss Orrys? I see you're calling about an appointment today. You know, that's a much more friendly experience. And they can take the medical record number, which is popped right to the screen, and just cut and paste it right into Epic. We found, you know, we took a lot of time just trying to figure out who we're talking to. You know, people speak quickly, or there's background noise, or, you know, just a bunch of different reasons why sometimes we don't get it right. And we've spent a minute sometimes just trying to find the medical record number. So this has been a huge employee satisfier as well as patient satisfier to now have so much more information when they pick up the phone and when they talk, you know, directly to the patients. So here's just some of our preliminary results, and I think these are pretty exciting, and they've really done what we hoped it would do. So when we started in January, our talk time was about 3 minutes and 56 seconds. We're down to 3 minutes and 30 seconds. So when you take 4 million calls a year, if you can shave, you know, 26 seconds off of each call, that's a huge win for us. We did see a little bit of an uptick, a little bit of a learning curve, which was to be expected. And I don't know if you noticed a little blip that happened that week of April 4th, but that was some internal things. It wasn't anything to do with the IVR. So, you know, as we stabilized after that week, we're looking at about 3 minutes and 30 seconds talk time. So, so really, really big wins from the system and from what we were looking for. And the time that they're spending on the call is, again, that value-added time. You know, they don't have to go into why are you calling and who am I speaking with. They've already got all those identifiers. So as you look at what you're going to do, just some recommendations. You know, putting in an IVR is a big undertaking. I would recommend having a dedicated team to implement this. You want to have people that kind of live and breathe this, and partner with whoever you're going to partner with to make sure that they're on board. We also had a steering committee at the C-level to keep everybody informed. We used a phased approach. We started with one of our smaller locations and worked out any little tweaks or any bugs, or you inevitably there's something that you didn't think about, and then we kind of spread quickly throughout the organization. Communication is also very important. We partnered with our marketing team to make sure that we were communicating and continually telling the clinics that we supported when the IVR was going to go live, what the patients could expect. We developed some flyers that went on the front desk so patients understood we've got a new phone system, what the phone system was capable of, some of the things that they could do in the phone system. And then kind of lastly, be prepared that some people aren't going to like it. There's a certain, you know, part of the population that just don't like change. They want the calls the way they were before. They don't understand why we're doing things differently, and that's to be expected. But you know, once they find out what it is, it will become the norm, and when they realize what they can actually do, it will, you know, it will be very well adopted. And then I guess lastly, I just wanted to real quickly talk a little bit about kind of what Brian said. It's really a lot about the culture. You know, our mission statement here at the Contact Center and for our whole access team is delivering the All For You experience is our privilege. And I think part of that privilege is not only when we talk to them, but at every encounter with us, every access point. So I think the IVR is part of that, and leveraging technology to get people what they want. Sometimes we forget about that, but it really needs to be part of the culture and giving people what they want as we see people want different things as technology and society kind of evolves. It's just kind of the norm for when you call a world-class business. So I will turn it back over to Brian.
All right, thanks, Cyndy. That was fantastic. So just in summary, you know, I think, you know, you just saw an incredible example, but whether you're in the crawl stage, the walk stage, or you're running, getting ready to sprint, technology can help you maximize the value of every interaction and drive a world-class patient experience in any one of those stages. So whether you just are creating a single front door to provide a unified, consistent branded experience and then route that patient the same place they would have gone to without that, at least you're creating that single point of entry and you're starting to capture data around that patient that you can leverage to drive more intelligence and personalization in the future. In the walk stage, now you're starting to pull certain tasks off of an already very overtasked agent environment and moving those into automation, and then handing off the more complex portions of an interaction to an agent with the data. So you've now got a perfect blend of automation and a live agent experience. Or if you're running and you're now looking to create a true omni-channel environment where you're seeing a patient across every channel, every interaction, and you're able to personalize those patient experiences based on that data, technology can help you get there. So hopefully this has been helpful and beneficial. And I'm going to hand it over to Lori now for questions.
Thank you. As Brian said, now we'd like to open it up for questions. As a reminder, please use the questions section in the GoToWebinar panel to submit your questions. If your questions aren't addressed during the webinar, you'll receive a follow-up email from someone shortly. First question, Cyndy, have you reduced FTEs based on the lower talk time?
Yes, we have. That was part of our ROI when we decided to do this. We have reduced 13 FTEs. One other thing that I didn't mention is we've reduced a lot of transfers. Our patients can now call any site and ask for anything. We find that patients are kind of creatures of habit, and even if their site only offers a small family medicine doctor, they'll call there and want to talk to their cardiologist. And now they can just say cardiology and get transferred right to that pod in the contact center. And they, you know, kind of another unexpected benefit was the cross-transferring has really been reduced as well.
Jennifer would like to know how many RN FTEs were you able to reduce versus agents?
That wasn't part of our scope. All of our RNs only get their calls from agents based on their symptoms. So we haven't reduced any, and that wasn't the intent.
Okay. How did you get buy-in from senior leadership?
Well, the best way that we got, well, part of it was the ROI, which kind of spoke for itself. The other part was we're lucky enough to have leaders that are forward-thinking as well, and we knew we couldn't do nothing. We had to start moving in the direction of the rest of the industry, and as far as contact centers, and I'm lucky to have a lot of support, and I'm always talking about the world-class experience, and senior leadership is on board with that. And you know, when I brought this to them that this is how we are going to get there and create a better experience, I was able to get buy-in.
You mentioned that 50% of the calls were scheduling related. What's the makeup of the other half?
I'm sorry, Brian, I'm answering all the questions. They are prescription refills, test results, just general information. I'm running behind, you know, all of those type of things. You know, for the most part, it's about 50%, even a little lower than that, are actually scheduling calls, 40 to 50%, and it's all the other things that people call their doctor for.
All right. Christy'd like to know, what source did you use to benchmark your volumes in order to provide appropriate staffing?
I did not use a source. I used our workforce management tool, so we used our real phone line data, fed it into our workforce management tool, and it told us based on talk time and arrival patterns how many people that I need at every 15-minute increment of the day. So I use technology for my staffing.
Several people would like to know what telephone system you use.
Siemens. It's a HiPath Pro Center.
Does the health system offer availability to patients through email, text, or video?
We do text appointment reminders. We don't do back two-way texting to communicate with your physician. You can confirm your appointment that way. And we use MyChart as our biggest, is our portal.
Okay. What are your plans to leverage the IVR in the future?
Well, you know, one thing that I'm really hoping to do is flu season's coming up. So I'm hoping to leverage it to where we can just say to the patient, if you're calling regarding flu shot, say flu shot. The patient will say flu shot, and it will take them to a list of all the locations and their times. And we don't have to actually talk to the patient. We get thousands and thousands of flu shot calls. So I'm really hoping we can leverage this IVR technology to offload those calls and answer the patient's questions without us even having to talk to them.
Craig would like to know what the key messages you used were to get your providers comfortable with centralization of scheduling. Was there one message in particular that worked?
Well, I think the biggest message was, at the time, we just were not able to answer the phone. We had a lot of very upset patients, and you really just had to prove yourself. And it was really about building that trust with the physicians. And we had a physician-led steering committee, and that really helped to get buy-in from the other physicians. But it does definitely take it takes a lot. You know, there are bumps, and it's not going to be perfect day one, but you know, if they see some of the gains and you start to, you know, build some trust and take care of some of that low-hanging fruit and show that the patients get a better experience, the agents sound better. That was one of the things I focused on first, because it's something we could control, is when the patient called, it should sound and feel different and better. They shouldn't feel like business as usual and people rush to get them off the phone because the front desk was overloaded and they had patients walking up and trying to answer the phone. When they called us, it was all about giving the patient what they wanted in first call resolution.
Jennifer would like to know what your typical menu consists of, and based on patient's choice, does it determine if they get a nurse versus a clerical person?
Our menu today is just, it kind of walks them through. You know, Brian helped us design a very robust menu where it's a, you know, we thank them for calling, and then we kind of ask them, you know, what are they calling about? And it leads us, you know, if they say appointment, then we ask them what service the appointment they'd like to see, and it kind of pulls them through. We don't have a nurse option. Again, they would get to a scheduler or a clerical person first, and then based on the symptom guide, you know, if they had a high blood sugar or some kind of acute symptom, we transfer them to a nurse. They don't directly go to a nurse.
Can you talk a little bit about what tools you use to assist schedulers with scheduling accurately? Do you use a knowledge base or questionnaires in Epic or anything like that?
We use both. We have a knowledge wall that's on our SharePoint. It's not exactly what I would like it. I'm investigating a CRM, and some of our services have developed questionnaires. But we have a very, very robust SharePoint that has what we call our protocol database. And it has every physician, all of their scheduling preferences, and all of the information about them and in their profiles. And then we use subgroups within Epic to help us, you know, get to the right place, and, you know, as many things we can leverage in technology.
Okay, when a patient cancels an appointment, is the doctor's office notified in the event that the appointment was critical, like an OB appointment?
No, they are not. We use the same criteria for what we use for when we do our outbound appointment reminders. So there are some things that we do not allow the patient to schedule through the reminder call or reminder text, and we've used that same criteria. So if we're calling to remind a patient of some kind of a critical CAT scan and they say, oh, I want to cancel that, we'll tell them they can't cancel, they need to call this phone number. And the same thing happens in the IVR if they try to cancel a critical test, a nuclear study, something like that, or a ambulatory surgery appointment. But your routine things, today we don't notify the clinic, and so we don't if they cancel in the IVR.
All right, we have time for one more question. Have you seen any impact on patient satisfaction scores?
No, we use Press Ganey, and we don't really have a question that speaks to this. I have very intently watched the remarks to see if I'm getting any feedback within the Press Ganeys about the phone system, and I have had none. I have had feedback from clinics and employees who are patients that has been very positive, and they really like the new phone system.
Okay, terrific. As I said, that was our last question, so we'll conclude the webinar. Thank you to everyone for joining us, and thank you, Cyndy and Brian, for a terrific presentation and a good discussion following it up. We look forward to seeing you at our next HISTalk webinar. Enjoy the rest of your day.